1958 Nobel Prize laureate Lindbergh has said, "The miracle that failed one child in a distant continent can reach youth today and defeat a global pandemic tomorrow." It's very true. Okay, nowadays. Let's review the history of deadly plague. I think the most famous is the Black Death in the Middle Age of Europe. It caused 25 million people dead, and prolonged the smallpox in Mexico, and the SARS in 2002, and nowadays the COVID-19. This is the COVID-19 dashboard yesterday. Now we have 62 million cases, more than 1 million deaths. And you can see the daily case is still very rapidly increased. So the pressure is very much. Okay, this is my agenda for today. The impact of the pandemic not only caused a physical but mental crisis, and in some countries it caused the health ecosystem collapse, and it also created a humanitarian challenge and economic shock. And we believe that this will reshape the healthcare industry in the future. Take women's health as an example. According to the Mary's Top International data, due to the COVID-19, 1.9 million fewer women have served by this program. This caused 1.5 million additional unsafe abortion and 900,000 unintended pregnancies, leading to the more than 3,000 natural deaths. And this is a tragedy. The impact on the hospital is huge. This is the diagram showing the measured and the predicted number of patients in ICU in Italy. The number of ICU occupation exponentially increased and beyond the capacity. So this caused the healthcare system collapsing in Italy. The Open healthcare system includes constraint of staff, bed, medical device, and PPE, and the physical mental stress on the provider. And because the large volume of patient loading occupied the original capacity of the system, this causes collateral damage to other medical services. And also the healthcare personnel may be unavailable because of sickness, quarantine, and escape from fear of exposure or concern about the family safety. And we also observed the admission to hospital, the volume is decreasing. This is the health system in New York data. You can see that in the peak of COVID-19, the mean hospitalization per week decreased to almost 1/3 of the basis in all kinds of disease order. The reason behind this decreased volume is, as we can see, fear of COVID-19 or lost income, unemployment, or lost employer based in insurance, responsibility for children of all men, an increased ratio for hospitalization by clinicians, and changes in the patient lifestyle in the context of social distancing, or just simply grief, anxiety, and depression. People decreased volume of the admission caused a big financial crisis on the healthcare system. So according to the Veterans Affairs of Connecticut Health System, they proposed the preparedness for the COVID-19 pandemic, include effective and accessible leadership with rapid and cohesive response. And hospitals should have a gatekeeping and screening at the hospital entrance, plus the off-site testing and good safeguard in the emergency room. And everybody should have the droplet precaution and should wear PPE and keep social distancing. The hospital bed should be redistributed according to the large volume of patient. And the healthcare worker team should be structured. The hospital should set up the testing criteria and order set to make the medical pass smoothly and rapid. And everybody should have mindfulness and awareness. This is the diagram of hospital capacity under different scenarios in UK, proposed by NHS. In the pre-pandemic area, usually the hospital has the spare space. During the surge of the COVID-19, a large volume infection broke the capacity, creating a deficit of capacity. With all intervention implemented by hospital to further create more capacity to accommodate the increased volume of patients, so that we still have a spare capacity to allow elective patient care. These are the hospital intervention, include cancellation of elective surgery, build a field hospital, and use a private hospital. Development of the former medical staff, development of new medical staff, or even medical students. This we have seen from the news. But the impact is different in different countries. In India, this country has 3 population times of USA and only 1/3 of physical space, and much fewer homeowners, less social security coverage, and 20% citizens live below the poverty line. Although the nation announced lockdown from March 24th, you can see the pandemic in India is tremendous increase. The large volume COVID-19 occupied the health system of India, so leading to the limitation of care to the non-communicable disease. So this is the dilemma of the India. The government should find a way to balance the two. Fortunately, we have many NGO, international NGOs, such as the Medicine Sans Frontiers, and they can help strengthening hospital capacity and patient care. They also support the long-term care facility or even refugee center and homeless shelter prison. The impact on non-communicable disease is huge. According to the WHO, in Italy, among those dying from COVID-19, 68 patients had hypertension and 31% had type 2 diabetes. A similar picture can be seen in other countries. More than 100 countries reported that the NCD services are disrupted across all kinds of disease patterns, especially of rehab service. The main cause of NCT service disruption include the following, such as the cancellation of elective care and lockdown, hindering access to the health facility, closure of outpatient clinic, insufficient staff to provide service, or even the unavailable stock of essential medicine, medical diagnostics, and health products. So how to overcome this obstacle is our duty. Many countries set up figure out some approach to overcome the disruption, include the telemedicine, task shifting, normal supply chain, and triaging to identify priority, or redirection of patients with sensitivity to alternate healthcare facility. The impact is on every aspect of the healthcare system. Let's take the surgery as an example. This is an international collaborative study showing that in the surge phase of COVID-19, the capacity is broken. In this stage, only life-saving surgery is allowed to proceed. When the separation strategy implemented, then increase the capacity to allow some elective surgery to proceed. During the recovery stage, the elective surgery, day care, and the outpatient can resume again. This is the course framework for surgical training in the pandemic phase. Preparation phase, pandemic phase, and the post-pandemic phase. Each phase has its own strategy. American College of Surgery also provide a COVID-19 guideline for triage of non-emergent surgery. There are 6 tiers. Each tier has its own definition. The COVID-19 pandemic also witnessed the telehealth revolution. The telehealth service include the telemedicine, video conference, and people can use smartphone or laptop to see your doctor, and the doctor can give you advice. During the pandemic, we can see much increase in audio and video call as community lockdown. The doctor can take care of their patient by mitigating the risk of spread of virus. The telemedicine also help reducing the demand on PPE, leaving the PPE to the most high risk groups, such as healthcare workers. We can use telephone to do the triaging of COVID-19. And using the home monitor such as glucose meter, BP, cuff, EKG, through the smartphone or smartwatch to pass the information to the doctor in the hospital. And the doctor can give you advice or even prescription. Encouragingly, the payer temporarily remove restriction of the payment to encourage people to stay at home. This is the good news. Through the telemedicine, the doctor can take history taking or visual inspection. The question is, can the doctor or staff make diagnosis or even prescribe medicine through such technology? Is it justifiable? This is the question. It depends on our innovation and wisdom to solve this problem. But definitely, the COVID-19 changed the outlook of telehealth. Before the pandemic, only 11% of people interested in the telehealth. After the pandemic, the percentage jumped to 76. From the provider side, the telehealth visits increased rapidly to 175 times. And as I have said, the regulatory institution removed the restriction of payment. The CNS just approved more than 80 items for the telemedicine. This is very good news. This is data from the New York healthcare system. You can see that after the pandemic, almost 2/3 of the office visits was replaced with telemedicine. This creates about 20% of all Medicare Medicaid spend of the health market. So this is a big business. However, this also reveals the health inequity in the area of telemedicine. According to the data analysis, the age, sex, race, income, education are all associated with digital access disparity. So how to overcome the medical inequity in this year is our duty. The impact on the healthcare staff is also huge. The overall workload, charges of PPE, new assignment, ethical dilemma, the patient priority, how and who to determine which one should treat it first. This is a very difficult decision with a limited resource. And self-safety and family concern. This data is from the early days of COVID-19 pandemic from China. In general, the healthcare personnel has a 3.8% COVID-19 infection rate. But in Wuhan, the epicenter of pandemic, 63% healthcare workers were infected. According to the China National Health Commission, in March 22, more than 3,000 healthcare workers have been infected and 22 died. In Italy, 22% of healthcare workers were infected and some of them died. The question is the healthcare worker infection rate is higher than the general population? According to a community hospital in New York, the answer is no. Because when you compare with the general population, the hospital in Raleigh had lower positive rate, 9.9 versus 16.7%. Is the different job has different infection rate? No significant difference in antibody positive rate across job title and work areas. But this also gives us a strong evidence that in the tertiary community hospital, the PPE does its job. How to support the healthcare workforce during the pandemic? We should provide enough PPE, and the organization should enroll healthcare workers away from the high-risk site. We should keep conversations with frontline caregivers, ensuring the core of healthcare workers' family to enhance workforce competence and availability. And the leadership should not emphasize the importance of self-care and provide enough food, rest, breaks, decompression time, and active time off. Unfortunately, there are social stigmatization, and in Libya, a medical doctor and paramedics were killed. According to the data from WHO, the attack on healthcare in the context of COVID-19 is increasing. How the impact on the psychological outcome of the healthcare worker? This is a study showing around 10 to 15% of workers has problem of depression, anxiety, stress, and post-traumatic stress disorder. This is the way to prevent the psychological impact on the healthcare worker. The pandemic also creates ethical issues. How to distribute the scarce medical resources among COVID-19 patients? How to distribute limited resources between COVID and non-COVID patients? And whether the lockdown infringes the individual right to seek health care. This is the news from India. A heart attack patient was denied treatment in Delhi. So how to maintain essential service by COVID-19? We should be using technology for transportation and improving the preparedness of healthcare facility, provide medicine at the doorstep, streamline travel during the lockdown period, and effective and transparent communication. As I said, the pandemic also caused the healthcare system financial issue. This is due to the cancellation, elective surgery, and inadequate reimbursement for long ICU stay. A profound effect on procedure-based specialty. The hospital may lack financial cushion as the hospital margin has been falling, and the ambulatory practice may be closed or bankrupt. The hospital may take steps like layoff and reducing the salary. So how can we learn from the COVID-19 for the finance aspect? This is the USA federal response on such and such, but this is all passive response. We need a proactive plan to prevent the financial crisis of healthcare system. Is there a better payment model? Some experts suggest population-based payment in replacement of the traditional fee-for-service. Looking forward, we can learn the lesson from this pandemic in the category of delivery of healthcare or healthcare structure, telemedicine, and patient assessment, and even medical education. In my view, the reshape of healthcare system in the future should include establish a healthcare system with resilience to cope with the pandemic while maintain daily medical service. A healthcare staff improvement system like veteran to suffice the demand of the pandemic. A more comprehensive healthcare insurance system to cover all citizens. A reform of healthcare payment system. We need more research and development of digital tech in the healthcare system. We need more public education of pandemic mindset. Our medical education should increase the context of epidemiology, public health, and medical ethics. And also the international cooperation and study system is required. Finally, we are one community with the common destiny. try our best to achieve the SDG. And well-being is one of